Thank you for coming. This is the second of a series of 3 brown bag discussions that talk about problematic substance use in child and family settings. And the first mental health concentration met a couple of times to talk about this. Students from Title IV-E said this would be a helpful thing to have happen, so that's why we're bringing this to you. The first brown bag was brought to you by Joe Glass and Colleen Mahoney, and we have some handouts here from that presentation. If you didn't get one, might be helpful for you. And we're just going to get started today with talking about interventions. Now the disclaimer is this is 50 minutes more or less with questions and answers, so we're not going to teach you everything you need to know about intervention during that time, but this is some things that we hope will be useful.
That's a good way of saying it,
yeah.
Right. Just to piggyback on what Peggy has said, if you want to kind of see this as a continuous flow, you work with families, you work with youth, and there's something, usually it's not a secret, that there's something to do with substance abuse involved with the family and maybe part of the family's issues. And so if you were here the last time, or if you look through the material, you'll see some ideas. So then how do we assess? Is this an issue, and to what extent is this an issue? And a lot of times circumstances dictate that in advance, and your assessment is more or less to help you fuel a potential referral out. So we'll assume that you've gone through that process and that you've got some ideas about a person's substance abuse affecting their roles as a parent and within the family. Anytime you talk about change, and anytime you talk about change in relation to habits or patterns that aren't healthy, you'll see or hear discussed at times the Prochaska-Di Clementi change model. You probably have seen this at some parts of your training. If you haven't, you will. And basically what Prochaska and Di Clementi said is that change happens in stages. It would be nice if it happened in these nice little box stages, like once you change, you're there, and then next time you graduate, and then it's like you never go back. That's not the reality of it. But just to help us conceptualize and understand, so you know where we're talking about, and I'm sure you'll relate to, pre-contemplation, this is the stage where, say for example, the family sees a lot of things maybe not working well, but their drinking or drug use is not a part of that problem. They are some folks say denial, but denial, you have to have some understanding of what's going on to deny that it's happening. And this is even probably pre-denial. This is not even being aware that an issue is an issue. Once you're willing, or the client is willing to see something isn't quite right, and it has something to do with substance abuse, we're now talking about contemplation. And this may be just the idea that you're willing to acknowledge there's some relationship between difficulties and substance use. If they begin to start to express some interest in doing something different, that's where we get into the preparation and action stages. Action, of course, would be the treatment and the change process. And then once some achievement has been accomplished, we have what we call the maintenance stage. Sometimes people use terminology like relapse prevention, but basically what you're trying to do is maintain whatever positive results the intervention has had. And unfortunately, people jump around, people change. Sometimes people say, well, this is an issue and I don't like it and I want to change it. And as you start talking to them, you say, well, you're going to need to talk to this significant other you have living in the house, because they seem to be a part of the issue. And it's like, well, I don't know that I want to do that. And so you see people shifting in the process. But for the most part, that's the general flow. And what we're going to talk to you today about is trying to get people hopefully more towards this stage and touch a little bit about action. But of course, as Peggy said, we can't get into a really comprehensive intervention. When you're talking about interventions with families or interventions with individuals within families, I think it's important to be practical with what barriers, other than the person's desire to change, you may have to deal with. It's very frustrating, I think, for referral sources or other entities within the system to get a referral from a social worker, a psychologist that doesn't take into consideration what's available and what's practical for the client. You know, could use a 30-day inpatient placement and then a 9-month placement in a therapeutic community, and there's no 30-day placements available, or they can't afford that, and the therapeutic community is 6 counties away. You know, those kinds of referrals may look good and make practical sense, or I'm sorry, make theoretical sense, but not very much practical sense. So just some things to understand. The research tells us can be barriers for women coming into treatment. Naturally, the lack of availability and funding is across all parties. Lack of gender-sensitive programming. What's an example of a gender-sensitive intervention that may be really relevant for women in treatment? Not necessarily only women in treatment, but would be maybe more relevant for women in treatment, do you think? Can you think of anything? What we know about substance abuse and treatment research, can you guess even? Can you make something up even? Anybody want to try and take a chance on it? Yes.
Like support groups or treatment groups that are like just for females instead of mixed, something like that.
Yeah, that's what we would be talking about with gender-specific kinds of interventions, and that one of them is and some programs that would only have females involved. Some of the issues that tend to affect females, substance abusers, more than males is a lot of times physical health issues, for example, reproduction system issues that wouldn't be relevant for males. A lot of trauma history. A lot of times females, just like males, have to do things to get money for their drugs that they're not particularly proud of, and they may want to talk about that in a setting that doesn't include males. Yes?
I know I read somewhere in research, this is a long time ago, so I have no idea where it was and if it's right or not, but that women's use is a lot dependent on like a relationship or a partner, so like relational issues.
There's oftentimes in research with gender-specific a gender-specific topic that they talk about the relational components, both in criminality as well as in substance abusing. So that could very well also be a bigger issue maybe in a treatment facility for females that may not be as much for males. There are certainly going to be issues that are pervasive across genders, but the idea that a gender-specific programming availability, when you're already talking about limited availability, is naturally going to be something to think about. The lack of support and stigma. There's a lot of cultural, social messages around females who abuse substances that they have to deal with on top of the general stigmas around substance abusing. And then of course the big issue, the practical one of what would happen with my child while I'm in treatment, and the other one being what will happen with my child in the system if I come forward and say I need help with my substance abusing. So that's often an issue of reservation that can affect barriers to treatment even for those who are interested in the change process. So when we talk about interventions, the capital I intervention, meaning as an actual structured approach to a person who needs help to try to get them to have help. How many of you have seen the cable show Intervention? Yeah, okay. That's not what we're talking about, all right? So quit watching that show. No, I'm just kidding. That's the old school, basically what you would see as the Johnson Institute intervention, where you're like saying, hey, let's go out for pizza. Next thing you know, you're pulling up to somebody's house. You're in the living room. There's everybody they know, and we love you, and you got to go to, you got to quit shooting dope. And it's like, you may be surprised to know that that's not necessarily an effective intervention, okay? And there's a variety of reasons why. Forget about self-direction and voluntary, but there's a lot of potential negative consequences to that. However, there were folks who did get into treatment that way, and it was enough to get them started. And in those cases, for those reasons, it was often used. And I guess the big point there is just that a lot of situations dictate what we're going to do. And the idea that if a person gets help, they were ready, and if they don't get help, it's because they're not ready, is really kind of a cop-out that a lot of folks in the field have used at times when a person has or hasn't been ready to enter treatment. The next two interventions are much more contemporary, and certainly ones you may want to explore. If you're interested in, you've approached a person, and there does seem to be some interest, this would be contemplation stage individuals. I'm just going to say briefly something about them, and Peggy can add if she has something. But basically what you're doing is, with the ARISE intervention, you're coming together as a team, and this isn't necessarily all treatment providers. This could be significant others with some treatment providers available, to talk about what have you tried to get this person to look at the issues, what has already been in place, and trying to get, not reinventing the wheel, and seeing if there's some areas for movement. And then coming up with some strategies in order to get the person motivated. And it can be tough love kinds of things that the Johnson Institute would talk about. For example, no more lending money. You can't live here while you're continuing to use. And in the case of the families, it may be, we're going to contact Children and Youth Services if you're out using, and we get words that you're out using. Family members may say that we're not going to babysit every weekend while you're out doing what you're doing, or whatever they may do that they feel would work with this individual. And then always preparing for crises, because that's usually the time in this situation where the person may be most prone to say, okay, enough is enough, and I'm willing to take a try. The unilateral family therapy is a little more structured, and this is often helpful in a situation in which you have functioning members of the family unit who are struggling themselves emotionally, psychologically with the using of the other person, and so they need some support as the process is going on, so that their whole quality of life isn't contingent on this other person's choice. And so you may go through some addiction education, teaching them more how to monitor usage, if there is some question of whether or not it's abuse. Talk about ways to enhance relationships. Talk about enabling behaviors, things that you may be doing that actually continues to promote the using. And then a program confrontation, in which you've already contacted a facility and you've kind of come down to the logical consequence choices of, we've talked about this, we've talked about options, and this is what's laid out for you. In our support to you go towards treatment, or a lack of support for you to continue the lifestyle that you're living. So this is kind of a combination of the first two, I guess, if you were going to try to just put it in a nutshell. Any questions about that particular style of a model? As a person who may be facilitating this would be certainly something you'd want more training about. But as far as interventions go, you don't need to be a drug and alcohol counselor to be able to facilitate this kind of an intervention. Okay. So what kind of language should we be using? And what should we be using to communicate as we approach the individual? And many of you have heard something about, or have had some training around motivational interviewing. And so we're going to use some of that language. You don't have to be a motivational interviewing expert or a motivational interviewing practitioner to understand the value of that kind of language. But just some of the key points about motivational interviewing is that they expect and they address ambivalence towards change, defensiveness towards change, and they express the importance of positive change language. So in other words, reasons why you may want to be doing something different versus reasons why you're having trouble changing what you're doing now. Okay? And just in that language, the practitioners of the motivational interviewing say it actually leads to motivation to actually do something about it. So I'm not going to read the slides to you, but we all have some level of ambivalence around change. If you tell me something that you want to do differently about your life, and you're not doing a lot about it right now, and I asked you about it, you'd probably have 1 or 2 reasons why you haven't really focused on it yet. Well, like I'm working on MSSW. What the hell? You want me to do everything right now? And, or there's all kinds of things that get in the way of us really being focused on the change. And motivational interviewing says that's natural ambivalence, and we may want to look at some of that. The other is defensiveness. Nobody likes to be told what they don't do well. And so part of your ego, which is supposed to be there, says, wait a second, I'm not going to let you talk to me this way, or I'm not sure I agree with you. Just because you say it doesn't mean it's true for me. And so the key here is, though, the more defensive a client is, the more their brain energy is invested in staying where they're at, and the less likely you're going to get them to take a step forward. Defensiveness can make a person who's in contemplation stage be very resistant to go to the preparation stage, because either the way you're talking about moving forward isn't conducive to them, or the whole relationship, the trusting vulnerability that needs to happen with change just isn't in place. So defensiveness is important. It's a clinical term. It's a reality, and it's something that you, as a family, somebody working with the family, may want to be addressing in a variety of different ways. Okay? So here's just some examples of motivational interviewing type of language that you could use in now bringing the subject of change to the family you're working with. One of the big keys is, of course, the permission asking component, where you're asking them, can we talk about your drinking? Can we talk a little bit about, you had talked about some of the struggles you're having with the kids and how much it's getting really stressful in here, and that you have ways, we talked about how are you dealing with it, and you were kind of vague about it. Can we talk a little bit about some of what I'm seeing as far as your attempts at trying to change? And see where they're at with that, because they're going to have a feeling of where you're going, but at least you're offering them the right to step back about that. Okay? You don't, and I put here as a tip, you don't have to start with, okay, so let's talk about how much you're drinking. You know, right away you're throwing that on the table. It can be something like, let's just talk a little bit about getting behind in some of the responsibilities of things you said was important. You know, you talked about missing appointments, and that's not something that's like you. Can we talk about that? And then as you get into that, then starting to tie the drinking or drug use to this change in behavior. This is so you can start to see explaining why this is happening as a connection to the substance use.
One of the things to keep in mind is that MI really is around the spirit of collaboration and a partnership towards change and respecting the people that are doing the change. And so it's a very different kind of a strategy than, you know, piling on somebody at somebody's house and saying, okay, we're taking you to treatment right away. This gives the client the opportunity to argue towards the changes that they'd like to see.
Right. And the flow of the conversation, again, is towards what the change would look like. So maybe rather than saying, you know, about the drinking and pointing out some of the bad things about the drinking, having them just talk about what makes you think you need to change, letting them talk about what that would evolve to, what that would look like. Again, they're driving the boat, and some of this stuff may be very clear and obvious, but letting them talk about that in words that is going to allow you to see the things they value. Because they may not say anything about their drinking. They may say, I'm not the mother or father I wanted to be. I'm not the kind of parent I thought I could be. I know I'm not good for what's going on in the house, or whatever. You can see where their value system is, which gives you a point of introduction. So what would it look like if you could be the mother that you want to be? Okay, and when those things don't happen, what tends to be some of the factors involved? And again, you're helping them formulate what may seem clearly obvious from some of the other things going on. So then the change talk again comes into place. Isn't so much what are the problems you have, because those are going to be, again, let's talk about reasons why I'm not going to be able to change, excuses to stay the same. So you're talking more about, how can I help you in this process? How can I help you get past some of the difficulties you're having? if you were to decide to change, what would you have to do to make this happen? What would we need to do first? If today you decided that this was not the way you wanted to be and you want to move forward, what would have to happen next for you? And again, they may speak in vague terms, they may speak in ideal terms, it's okay. You're going to get an idea of the direction, and part of your role there may be, well, can I help with that? Can I make a suggestion? Or these are some options that folks in that same situation you're in may have explored with some success. Would you be interested in hearing those? And again, it's very helpful if you have materials related to treatment, related to 12-step programs available, so that if they get to a place where they've stepped up and they're getting a little bit nervous about making the next commitment, that you can say, well, can you look these over, see what you think? And maybe there's something we can talk about the next time we get together. And not leaving it just at that. We'll talk about that when we get to brief interventions, but so that they can still continue moving forward. One of the problems with decisions to make changes, this is why these wait lists to get into rehabs are so frustrating, is that once a person openly says to somebody, I do think I have a problem and I want to change, what do you think happens to them emotionally? What starts to happen to them emotionally? If you've ever released something like that by sharing it with somebody, what has the experience been for you? Do you feel bad afterwards, or do you feel kind of relieved? Yeah. Okay, at times you may feel vulnerable, especially if you're viewing what things are going to potentially happen. But one of the things that happens sometimes is people actually feel like a weight's been lifted. Now I've talked about it. Now I see that I got to do something. And as they start to feel better, that actually works against you in some respects, because their motivation now to do the next step can sometimes go down. And so you'll see people say, well, maybe I don't drink as much as other people do. And I do feel pretty good. And there were times in my life where I wasn't drinking as much. So you want to keep the ideas around the change and the need for change there without harping on it, but you still don't want them to slip away from that.
Yeah, and one of the things that often happens with our clients is that they've had the experience of identifying something that would move their lives forward in a need, and having wait lists and delays put into place. And so that's why it's really handy to have additional materials. And when we do our next brown bag sometime in the beginning of this next semester, we'll be talking about resources, additional resources.
It's very nice to be prepared for that, because if you have folks who are willing to take some steps and you can't take those with them, you can lose some of the momentum that might be beneficial at that point. And then discrepancies are a little more complicated, but certainly they're a way to help maybe refocus a person who is slipping towards denying or kind of altering their reality a little bit in a way that's more appealing to them, but not necessarily conducive for the change process. And in this we talk about discrepancies. So for example, you wouldn't say, well, you spend all this money on crack, you mean to tell me you don't think you have a crack problem? I mean, seriously, that might be a little bit harsh. So you may say something like, well, help me understand, on the one hand I hear you saying you're worried about keeping custody of your children, yet on the other hand you're telling me you're using crack occasionally with your boyfriend. So how are those two working together? Help me understand the relationships of the two of those. And again, it almost sounds, I guess for some folks, it almost sounds kind of facetious, but really what you're asking them is to be reality-based in what their goal is, and really what their behaviors are in relation to that goal. The problems with folks who struggle, especially with personality disorder kinds of things, isn't that what they want is distorted. It's that the things that they want are very much like the things that we want. It's the way they go about getting those things that tends to get them into trouble. And so you want to ask them, is this really conducive to what you want? Yeah.
And also when we talk about ambivalence, really the meaning of that word is having values on kind of both sides of an equation. And so people will be always wrestling with, what's the risk of staying the same? What's the risk of change? And depending on the day, may be on one side or the other. So this idea about building discrepancies is really where the motivational comes in, so that the desire to stay in the same painful situation begins to lessen, and the desire to move towards something positive begins to take frame.
Well, and if you have a rapport with the parent or the family you're working with, which, you know, hopefully you would have a connection that they could maybe talk to you about things, and because you're there with them, you know, making up things about, you know, how well they can take care of the house, or the structure in their life may not be as an option for them, so you're more real with what's going on with them. You could even use this kind of discussion to help them go from pre-contemplation to contemplation. So when you say that, you know, drugs aren't an issue for you, and, you know, and you spend this amount of money each week, just a party, you know, just a party, how does that come in line with some of these other budgetary things we've been talking about you struggling with? Because I know you value your kids most of all. So if this money is going towards something other than your children, how do you make sense of that for me? And then this can help them, you can plant a seed. You could get you know, why don't you mind your own effing business and stay out of my stuff? But the seed is planted, and the distortions become more and more challenging to be able to maintain if you've had them look at it from a different perspective. Okay? If you're the rapport, the person who has some rapport, and the person is just not practical, two things. One, it's going into treatment at this time is not going to be practical for them, or two, the level of usage is low enough that there is some possibilities for some entry-level kind of intervention. One of the things that has gotten a lot of support through the literature is a brief intervention we're talking about. And a lot of it you'll see in medical literature, primary care physicians have, for example, been trained to use it. And the reason why I think it's ideal for child and family workers as well is it's an intervention that comes at a time when the symptom of the issue is pretty bare. It's like right there. So in a primary care physician's office, for example, where a person's getting reports about their liver or about some other physical effects of their drinking, they may have their ears open towards, so you want to hear something about drugs and alcohol and how it's affecting that. The same thing can be said for a person who's spending a lot of time with a family that's struggling with children or family issues. Can we talk about ways, you know, it's not just your parenting here that I'm not talking about that. Your parenting skills are fine when they're able to be used. It's the times when you're not functioning as the kind of parents you want that we want to talk about. Can we talk about some of those things? Because the consequence here, 99% of the time you can be a great parent, but that 1% of the time can be very detrimental. So can we talk a little bit about that? And usually it works best if it's at a time when the person may be most open to at least hear about the process. The components, the common elements of brief intervention are, you know, pretty straightforward. This is not a time to try to explore deep existential insight. This is very clear. This is the third time that we had an appointment scheduled. You weren't able to be there. They always seem to be around weekends and on Mondays. There's been some reports about your using. Whatever, you know, a very clear sign that substance is there. And I want to tell you I'm concerned about that. I'm concerned about that for now and for moving forward. Okay. The responsibility for personal change. These are things that, you know, you basically are going to drive the boat for. I can't do these things for you. I can be available for you, but these are things that you're going to need to make the changes around. You're much more directive here. Again, this is why even with primary care physicians, you don't need to be a trained clinician to do this. You're basically saying, this is some of the stuff that I'm seeing, and these are some of the options that are available for you. And again, but the empathy piece, that I know it's not easy to make these choices. It's not easy to look at these things that maybe have been your only source of comfort, and to say that I have to give these up, or that I'm going to need to do something different, or to say, depending on the culture and the family and the community, to identify yourself as somebody with a drug and alcohol issue. So you're trying to show some empathy about that, but always emphasizing the self-efficacy, that you can change, you can make things different here, you can be the person who turns this around. And that's the piece that we want to stay. We don't want to continue to have a person feel hopeless who uses substance abuse as a way of dealing with hopelessness, right? You don't want to be sparking the very symptoms that kind of make substance using more likely to happen. So there's really 5 steps to the brief intervention, right? So the first one is conducting the assessment. And this is what Joe and Colleen talked about last time. But you're basically, at this point, looking at that what you're seeing is tied to substance using, and that's important. Is this the substance using, and is it the substance using with the person that you're talking to, or is it a significant other that's involved, or is there some other mental health issues or other kinds of domestic issues that you want to be aware of? So that's a key piece. You know, sometimes the symptom is clear, but we don't always know the underlying pieces. We want to make sure that we're going in the right direction. And then giving just direct and clear feedback, okay? This isn't about, you know, you can continue to do this and we'll just keep coping with it message. This is not the time for that. There's a difference between being direct and clear and, you know, being demanding. Here you're just trying to say to them, this is what I see and this is going to continue. This isn't going to improve if these things don't change. So these are the possibilities down the road if this doesn't get, if you don't do something about this, okay? Am I clear about that? Okay, because sometimes people really struggle with that in a domain where we're used to self-directedness of the client. And the issue here is that self-directed choices this person has been making around their using hasn't been healthy for them. And so you want to help them. In a brief intervention, you want to help them see that and tie it directly to whatever it is they want to see different. And then coming up with some type of a contract towards changing, okay? So it may even be cutting back on what they're doing. It may be budgeting the amount of money they're spending on their drug of choice. I mean, it doesn't have to be becoming Parent of the Year overnight. Okay, it can be anything in a step towards a more effective way of functioning. There's no better motivator than success. And if somebody can show that I can cut back, and actually I see the quality of my life changing, and I can be successful at it. I used to work with a guy that did substance abuse counseling, and he used to always tell the guys that came in, you try being clean for 90 days. If your life isn't better after 90 days, I'll buy you your next 8 ball of cocaine. And he says he's never had to buy an 8 ball. Okay, so and probably I know some folks who would have went back just to get the 8 ball. But anyhow, that's a different story. But the key is that if the change process, we know, if the change process starts to happen, they're going to see some benefit of that. And so you want to get something that's reasonable for them to do, and put that into a contract short term that you can follow up with. And then the behavioral modification techniques, to actually do some play with them, role play with them right there. So let's imagine I'm the guy that sells you the crack, or I'm the person who you get high with, and I come to your house and I say, hey Lucy, let's go get something. And I'm feeling good and I got a couple dollars. What do you say? And actually role playing some of the refusal skills or some of the other kinds of skills that they may want to put into place. Or if they need to talk about separation, you know, of course that can get much more complicated. We know with, God, we got painfully reminded this weekend sometimes about how separation can go in a lot of bad directions. So you don't want to just loosely jump into something like that, but still talking to them about something they may want to do and walking with them through those steps. This is not the time to step aside and say, well, let me see how self-efficacious you can be. This is a good time to say, all right, I'm going to walk with you these next couple steps, because if we can get this done, then we can move forward with some of this. So it's a critical piece. And then to have them again, this is the bibliotherapy piece. You don't necessarily have to do all the work. There's a lot of material out there about substance use, the effects of it, substance use in the family, substance use, the collateral damage to kids. You can maybe give them something that is relevant and just ask them to read it and ask them to pick a time where you can come back and talk to them about what it is that they're reading. So you've sparked the idea, they're motivated, but you want to give them some education behind why this is an important idea. Okay? So you can see this doesn't take a lot of time, and it's something that you can probably practice fairly easily. And then a continuing care plan, and this is not like an aftercare plan. This is a simple, I'm going to call you again Tuesday, or today's Tuesday, I'm going to call you again Thursday. I'm going to ask you just some, how are things going? This is not me checking up on you, this is not me investigating you, just to see how these thoughts have happened, and since you've had some time to think about it, and what you would like to see happen next. And what I want from you is just simple, straightforward answers, whether it's, I don't want to talk to you anymore, or this is what I've been thinking, and this is what I see, or this is what I'd like to learn more about. And then do it. Okay, follow through with it and make sure that it happens. Okay? Any questions about brief intervention? Yes?
I have a question about what happens after 2 with the direct feedback. How does one know if the person is ready for 3? What are you doing some more assessment on what response you get, or you just keep going without much?
That's a good question, and the reality of it is it's not one of those things that's very complicated. Once you give a person clear feedback about what's going on, the response they give to you will determine what your next intervention may be. It could be something like, okay, then I won't talk to you about it today, but this is not something that we can ignore. So I'll give you some time to think about it, and we'll come back to the subject later on. Okay, that's the worst case scenario where there's complete shutdown. The other is, are you willing to hear more about this? If I got somebody who's been in recovery, who's been in a similar situation to you, that would be willing to come and talk to you, would you be willing to talk to them? That may be what you need. I have some materials about A, B, or C. Would you be willing to read it and just talk to me about that the next time I visit? Whatever, this is, again, probably you have a better instinct about this than you might give yourself credit for. But what level of intervention do you think the person would be open to? And when in doubt, suggest the most significant, and if they say no, take a step back. Well, if they called you, would it be okay if they would call you? No. Well, if I had some people who are willing to share their stories with me, could I share that information with you? All right, I'll talk to you about it. So whatever intervention they're open to, that's the intervention you bring to them.
Another thing I would just say is that when a person is kind of stuck there is that, remember that bit about building discrepancies and working with ambivalence, is then engage in a discussion about what the person does want for their life and what kind of parent they do want to be and what they do want for their children. And then you can kind of circle back around to some of the suggestions in that. So it's not like you do this and then you do this and then you do this. It's like everything else in social work, right?
Right.
It's like you're constantly kind of working on multiple levels at once.
And you can go back to the motivational interviewing techniques and say, well, let's assume that we don't do anything. Let's assume that we quit talking about it today. How do you think things are going to look a month from now? How do you think things are going to look a year from now? And in relation to what you want. And again, you're checking that. And if the person is completely not willing to look at that, then it's your job to bring the ideas and options to them, right? And then if the consequences result from them not using those options, then those are consequences in some respects they have chosen by not exercising those options, right?
One other thing is, too, that especially with women who are using various different substances in order to deal with various different kinds of things like trauma history and all of this other kind of thing, that it may be very scary to think about letting go of this particularly, very effective coping mechanism, right? So sometimes looking at that can be helpful in terms of helping people get to the point where they're saying, okay, maybe I can look at an option.
Yeah, and that's where talking to them about the inclusiveness of an overall therapy program and the benefit of some of that is also good, because they may not really be clear on what's available to them.
Or that there's hope that things could be different.
These are some of the intervention strategies that kind of support the intervention itself. The other, and I alluded to it a little bit, you may have heard harm reduction, the harm reduction approach. How many of you have heard the term harm reduction? Okay. Harm reduction can be somewhat controversial just because it doesn't talk about abstinence in the way that historically substance abuse treatment has. But the idea around harm reduction, the overall goal of it, is that people will start to experience some benefit by improving their behavior and functioning that'll allow them to keep taking those steps forward with an ultimate goal of perhaps abstinence or whatever managed usage that works for that particular individual. The basic tenet is that it's kind of an alternative to the moral or criminal and disease models. So this whole idea that you're afflicted with this allergy to a substance, and if you keep using it, your life just continues to get worse, which has also research support, but still, the person may not look at it, be willing to look at it that way. And so the idea of abstinence is the goal, but there's some sub-goals involved. So for example, in Great Britain, they have a heroin maintenance program. Where people get prescriptions for their heroin, they go to a pharmacy, they get heroin, they can use it, and they go to work and they don't have to do all the criminal things around getting their drug. And so it's similar to methadone maintenance, only they use heroin because it seems to be less physically damaging than methadone can be. There are other kinds of programs, we'll talk a little bit about some of them here, but the key is that you're trying to reduce the impact of the usage to a more functional level, I guess would be the best way to describe it. So, again, we're looking at a spectrum here. So people's habits can be a continuum of harmful consequences. So you have that person who misses an occasional electric bill because they spend too much on drugs, versus the person who disappears for 3 days and the kids are left alone and you've been brought in, and anywhere in between. Okay, and the idea here is that it's not one-stop shopping, that you're going to this one person who has 70% of their life functioning reasonably, and telling them you need to go to a 30-day inpatient program. The same thing on the other end of it. You're not looking at somebody who's tried a bunch of things and you're telling them maybe you just need to go to a couple 12-step meetings. This is a kind of an in-between, closer to where their goals may be. And any step towards decreased risk is considered a step in the right direction. So there's definitely an empowerment piece to that. So it can be, there are folks who quit using needles because of the diseases involved with needles and blood transmission. So they may continue to use heroin, but they agree not to inject it anymore. It could be drinking wine or having a drink with your friends is still acceptable, but we're going to stay away from using other harder drugs or other kinds of drugs that you may have addiction to. Anything to, you can party as much as you want on Friday, but other than Friday, you're abstinent. So these are all attempts, and it can do two things. One, it could reduce harm. The other can also, if they're having difficulty managing even that, then you have another piece, kind of coming back to Joe's stuff last week, where these attempts at managing it and not being successful may help you getting them to at least look at this needing more serious intervention. Okay? And this is kind of the key features related to it. It's questionable always as far as the stigma associated with it, but at least it allows them to look at a different person, different than they are, that may not be as drastically different as what you were initially proposing, where they were like, I can't even imagine that. Because remember, substance using can be a lifestyle. And you're not just talking about stop using. That may be their sole source of income. It may be all of their friends. It may be all of their leisure. It may be so many different things you're asking them to walk away from. And here you're just asking them to make a change that's a little bit more reasonable for them. Okay. And these are some examples of harm reduction programs that have been put into place. Again, when we're talking about family intervention, it could even be, finding someone to babysit the kids on a certain day that you know that you're going to be doing whatever you're doing. It can be a variety of different things. It's an attempt to try to help reduce the amount of damage that the drug is using or causing and the drug use is causing. Okay? Questions about any of that? And then this is just some resources that actually, these resources were provided to me by Rosemary, who has been a real asset to looking up things since we've been talking about this topic. So these are ones she actually got in our library. So you can get these pretty easily, but there are others as well. Some of these are older editions. You may get newer editions, but the fact of the matter I always find is that sometimes you look at these and then you look at their bibliographies, they can give you other ideas. And these are all around substance use, family dynamics, and again, what level you want to be involved in. You don't need to be a treatment provider to do a lot of these things. But I can tell you, having been a provider, it's really helpful if your referral source is educated about what's going on, so they can provide you with information that helps you target your intervention. And sometimes that's the key piece, because you're starting to fix and work with things that are the real issues and not issues that you're trying to gather from a variety of other sources that may not know the family as well. So something to think about, and hopefully that's a good tie-in to some of the assessment pieces, and we can take some questions, I guess, at this point.
Yeah. I would just say that start the conversation. Be willing to start the conversation from a non-judgmental, collaborative point of view with clients, and I think that you will find that it will go better than if you kind of do it as a checklist. Are you using drugs or alcohol? Yes, no, maybe. So I just wanted to throw that in.
And that's a good point. The other piece of that is to kind of, not to put a lot of pressure on you, but what the hell. When you're there and you don't say something, you're implicitly condoning it. So the idea, you're not coming in and saying this isn't a big deal, but if you come in and you see some things, you see a spoon with some carbon on it because it's been heated up or bent funny so that it can sit by itself, and I don't eat my cereal that way, something's not right, and you don't say anything about it, in some ways you're saying this is okay, or it's not that big of a deal. And folks can internalize whatever message they want from that. And, much like suicide prevention, talking about it doesn't all of a sudden make them want to do it more. They may be looking for someone to talk to about it. So.